And I'm going to push back. But let's start with a general perspective that I took in looking at the situation we were in and why I adopted a positive view of the Affordable Care Act when it was presented to the country, and still do. There are three basic considerations that have to come to mind. One, thinking about the time that we were passing this law, was that we had to reduce human suffering. Then, starting in 2010, progressing in 2013, we had to proceed with that because the same opportunity to reduce that suffering in 1994 with the effort to expand health care had been tossed in the trash can. And tons of money had been spent over the ensuing years without a pause to even consider the suffering of not getting health care. The second was we had to come up with something that would address the political realities. There are a lot of interested players in the healthcare market that we have established. So whatever had to pass could not simply upend and say, congratulations, we're now the United Kingdom. It had to be something that could pass in the United States of America. And third, it had to have tolerable costs. Whatever the cost of extending coverage to people has to be a cost that is affordable. And I'll make the case to you that it is. But let's just remember the atrocious realities that apply to actual human beings in the United States. This is data from a survey prior to the passage of the Affordable Care Act reflecting cost burdens, comparing U.S. uninsured individuals on the far right who report either didn't fill in prescription, that's 36%, didn't see a doctor or get care, that's 58%, or had greater than $1,000 out-of-pocket expenses, that's 39%. Still pretty rough actually for U.S. insured because we have more cost sharing than other countries. And yet the United Kingdom, Canada, Switzerland, much lower levels of suffering due to these cost barriers. And that's what we needed to address. The pre-Affordable Care Act market, whose loss I will not grieve, I would say good riddance. It was a disaster too, and any hint to the otherwise strikes me as off base. Essentially the way it worked was that they used underwriting and the rejection of consumers as central premises to figuring out who should get care. In filing data obtained nationally, the rate of denied applications for insurance was 19% in 2011, rising to 22% in 2013. That's an insurance company saying, sorry, we don't want to do business with you. That doesn't mean that all those 22% couldn't get care if they simply reapplied several other places. But a survey among people who shopped for insurance in 2008 found that 57% found it difficult or impossible to find an affordable plan, 70% if they had a prior health problem, 73% simply gave up on the shopping exercise, and coverage typically covered less than 60% of the costs that they incurred. There was restricted mental health care, and as part of the ordinary underwriting process, pregnancy was not typically covered without a rider, leaving women and women were charged more, of course, as the kind of lower 50% of the population whose little health problems could be handled by charging them more. The Affordable Care Act has been well described, but its basic premises here: Medicaid expansion. Everyone gets access to the insurance market, which is thoroughly re-engineered. Insurers can't deny or price on health status or being female. There's subsidies. There's no lifetime maximum on the amount of benefit. Young adults were continued on their parents' plans up to the age of 26. That's actually 3 million people who are enjoying that benefit, who are not in the counts that either I will show you or that Tom showed you. And there's a mandate to employers to provide, with many exceptions, some taxes and cost control efforts in Medicare. Let's talk about just big picture, where are we? So the number of people uninsured, according to the CMS actuary, is down 17 million from 2012. This is, I think, the fifth or sixth different sourced estimate I've provided on the number of people who are insured now compared to before. So they all come up with different ways. You can say that not all of it's due to the Affordable Care Act, but that's the change. And there is a growth in expenditures that tempered. This is the pace in 1985 on the far left at 9.3%. And, as we came out of the recession, basically, there was a tempering of the pace of year-on-year healthcare expense growth, which has ticked back up 5.3% in the last year, and it's predicted to remain between 5 and 6% for the next 10 years. So that's a real issue, by the way. I'm not trying to suggest that's an enormous success. Obviously not as bad as it used to be. There clearly were implementation problems with this law. Sort of sad, happy. Here's President Obama saying, I think it's fair to say the rollout has been rough so far. At this point, the federal exchanges are functioning well. report on the IRS is that it has insufficient data and systems to actually enforce the mandate. That's a very new report. But the good news is 7.5 million people sent in their penalty payments this year without much enforcement because we, the United States, have the highest tax compliance in the world, 85%. We're higher tax compliance than the Swiss or the Germans. So the IRS needs to improve its mechanisms clearly, but basically we're not a nation of liars, cheaters, and thieves. New Medicaid enrollees are costing more than was originally hoped. This is likely due to pent-up demand, and also the states decided actually to offer higher capitation rates up front in their Medicaid managed care plans, and thus it just initiated paying more at the start of the Medicaid expansion. That's thought to be likely to slow down by the CMS. Every year there's a set of predictions about how this is going to be disastrously bad. You've heard a set of them. Here, this is from Breitbart. Ways Obamacare is ruining lives. And of course, Tom was sedate in the way that he presented them, but nonetheless packed a punch. And it always resembles to me a kind of a Sharknado disaster movie. And I hear the same disaster predictions each year. But how many of you saw Sharknado 3? Just show of hands. Okay, 2. See, that's the problem with disaster predictions. This is actual tomatometer ratings. Sharknado 1, Sharknado 2, Sharknado 3, they just get stale after a while, particularly when the facts don't bear them up. So let's look at some of the Sharknado scenario predictions. People won't honor the toothless mandate. Employers will eliminate insurance for up to 35 million people. Tom presented that data here 4 years ago. It will be all costly, older female patients, no young men will get on these plans. That'll drive the cost up. You heard a bit of that argument here. Part-time work is going to surge in America as employers recognize the incentives in the mandate. Premiums are going to skyrocket. So let's talk about reality. Well, people did sign up. 13 million enrolled on the exchanges. 10.4 million are actually continuing to pay up. Employer offers of insurance are basically stable. I actually heard the source of this prediction is a former CBO chief. I just heard him on the radio yesterday explaining that in his business, it would be economically possibly interesting to not offer insurance, but he just can't bring himself to do it. He feels like it would hurt the culture and the workforce. And so he's decided not to do the very thing that he predicted everybody would do 4 years ago. Exchange purchases will all be sicker, older, and female, no young men. Well, 34% of exchange purchasers were under 35, half are male. The more signed up who had poor health at the start, somewhat poor health. So that's true. The question is not, is it perfectly reflective of the population, but rather, are there enough to create stability in the price structure? We don't need 100% representation. We need a stable enough structure, and I'll show you that that's the case. Part-time work will surge and premiums will skyrocket. I'm going to show you a slide on part-time work, but 85% of the exchange purchasers are receiving a subsidy. So obviously from their perspective, it's not skyrocketing. We can talk about the federal budget in a moment. Now, did employer mandates kill full-time jobs? This is the data on full-time versus part-time job growth. There are businesses that have taken their 32-hour-a-week employees and moved them down to 29 hours. It's a few 100,000 people. But broadly speaking, full-time work is on the growing and part-time work is stable. So objectively, we simply haven't had the employers respond to the incentive the way that you just heard presented. Okay, let's talk about massive Obamacare premiums increases. Not so much. So if we look over the previous years, 2008, 2009, 2010, this is just this past year. What the white bar is the actual year-on-year premium increase based on states with public filings up to 10. So 9%, 10%, 11%. 2014, one estimate I saw is it's actually from Commonwealth looking at this 0% increase. This is the past year, the premiums that are being paid right now for the current year. I saw another estimate of 1 or 2% for the second lowest cost silver. So clearly, there hasn't been an explosion last year. Now, what about the coming year? Premiums are going up and down, even within states. California has a confirmed average figure of a 4.2% increase, which is an increase, partly because their exchange has actually actively negotiated the prices to obtain on the exchange. This is not bad. Currently projected in a study of 8 states with complete filing data. This is very important. Avalier, a consulting company, says plus 1%. So again, not a skyrocket. Now it's true, as Tom showed you, many insurance programs have to announce if they are planning to increase rates over 10%. They have to present it as a proposal, and they have to go through a regulatory process. And those announcements make for great headlines. But if you look at states where all the data on all the insurers have been put together, that's not what the overall picture is. And obviously for the exchange purchasers, many are getting a subsidy, 85%. So their actual price from their perspective is quite reasonable. What about the cost control situation? Because obviously you've heard a lot about that. And do I think that this law has promised and delivered on bending the cost curve? And I think the answer is not yet, and it may not. But let's acknowledge that the drivers of our cost situation clearly are complex and predate the Affordable Care Act. Aging baby boomers are going to require more cost. They're a major part of the cost projections of the future. There are rising pharmaceutical costs. We have no real regulation or pricing for the new technologies in meds. There's eventually competition can sneak in for some of these pharmaceuticals. There are a lot of high-tech devices where Medicare is simply prohibited from prohibiting it based on cost-benefit considerations. So Medicare will grow. And as Tom pointed out, providers are gaining market power through consolidation, which they were doing before the law. We can argue the law increased that, and we can talk about that in the panel. But those are big drivers of cost increase. So what about bending efforts? Well, within the ACA, and to some extent outside the ACA, the following things are being attempted. Hospital readmission reduction program with payment penalties related to readmissions, bundled payment programs, payment rate adjustments are available if Medicare exceeds certain rates of increase, promoting accountable care organizations, medical home initiatives, primary care transformation programs. These are things that Dr. Curry mentioned. Has any of these delivered some major bending of the cost curve yet? No. No. We don't know the answer. We don't actually have a specific, clear, crystal understanding of what to do to bend the cost curve. This is a bunch of stuff that's being tried. More stuff is yet going to be tried. Are we on our way to a spending disaster? In some years, Tom likens us to Greece with a debt disaster on the horizon. So I just want to point out, picture from my son's school. There's America. There's Greece. Which one's on top? Total U.S. healthcare spending moderated in the last few years, but it's projected to return to 5 to 6% yearly growth. That is serious. We're not Greece, and we're certainly not China. Just to remind you of the difference between countries that are having real debt crises and us. When did they end their dictatorship? Let's see, Greece did it in 1974. We did it in 1776. Legally ending requirement for dowries with marriage. Greece did that in 1983. We don't really have that. Gross domestic product per capita, massively higher in the United States. Corruption, higher scores worse. Greece is much more corrupt than the United States. Well, I'm saying this is what the world perceives in international surveys, which is going to relate to the bottom of this slide. Government debt as a percentage of gross domestic product. Greece has overall government debt of 157% of its gross domestic product, third in the world. We're 37th. We have a debt issue, but it's just much lower. Number of patents per million people. We are an innovative country. We produce the third most patents per million people. Cost of government borrowing. When the world looks at Greece, they say, you know, I want to borrow? 19% will be your interest rate. When they look at us, they say, you want to borrow? 2%. In fact, the world uses us as their piggy bank because they don't know what to do with their money otherwise. So we have time to work this out. We are an innovative and dynamic country. Ultimately, I think the issue of coverage drives my response, and a lot of it comes down to understanding the history of how we set priorities for people who are poor. In 1994, the Clinton plan basically was trashed. And over the years that followed, we developed an enormous surplus in terms of federal money. And in 2001 and 2003, we put the bulk of it into tax returns for people who are well off. And to me, that priority was the wrong one, but it left me personally desperate to see somebody address this problem whenever they could, recognizing that even when there's tons of money available to spend, the poor are just not a winning political cause. Can we afford it? This graph depicts the actual costs of the insurance expansion as of 2023. And it only assumes that some money comes in based on actual taxes. It doesn't assume some giant savings. It assumes that even all the law has savings in it, it doesn't assume any of them are realized. So Medicaid and exchange subsidies cost money. This is for people who will be insured in 2023. A little bit of income on fees and penalties. Net cost in 2023, $132 billion that year. That's a real substantial amount of money to insure people, assuming there's no offsetting savings realized through Medicare or anywhere else. Those are all from CBO figures. So is that a money total that we can afford? So again, actually every year I have to make this slide anew because this dollar figure has actually gone down every year. The cost is lower now than it was projected to be 2 years ago. Here's $132 billion, which we apparently people are worried we can't afford to care for the poor, like 17 or 15 or 12 billion of them, depending how you want to emphasize. Those tax cuts I talked about, they were rendered permanent at the end of 2012, January 1st, 2013. They were rendered permanent. And the projected impact of that in 2021, which is a comparable year that I could get out of a congressional report, was $519 billion we won't collect. There was no great anxiety about not collecting $519 billion. Everyone was like, all right, that's what Congress needed to do to avert a government shutdown. That's what Congress needed to do. So to me, this looks like a small amount of money. But let's talk about the real issue, which is overall national health expenditures, which are projected to be $5 trillion in 2024. That is a real serious problem. Government expenses are projected to be $1.3 trillion in 2024. That's a real serious problem. And someone wants to tell me that we should really be worried that we're spending this little sliver here, and that if we could just get rid of this little sliver of coverage, we're going to address this problem? Nuts. Nuts. So in the end, the moral judgment that leaves me supportive of the Affordable Care Act, I mean, I've given you an argument as to why premiums haven't risen in the way that would suggest some sort of disastrous insurance death spiral. It's just not happening. But what's the moral judgment in the end? It's like a boat. This is the United States healthcare system. At that point, it's $2.4 trillion, I guess. But of course, it's not entirely stable. We, as a country, spend more money than we generate. We borrow to support that. The pace of healthcare expenditure is high. So there's a kind of instability. It's like we have a leak in our boat and we're pumping some of the water out. But it's not a perfectly stable situation, and we know that. And there's a number of people on the boat. But of course, there's a number of people not on the boat. So just imagine you're on the boat, insured under 26-year-olds, most of you, and you see these people out on little boards because their boat crashed, and there's a tidal wave coming toward them, and there's a vulture kind of circling overhead, or a sturgeon just waiting for fresh carrion. That's the people who we're covering with $134 billion. What are you going to say in response? And given the realities of our politics in 2010 to now, one is, this is an unstable situation. We're going to head back to port, patch up this boat, and pick you up a year or 4 from now. Love ya. Or are you going to say, get on board. It's not much extra weight, and we're going to have to figure out our problems as we go along anyway. Or, gee, maybe we should have picked you up 10 years ago, but if we take you in now, we're going to sink. Sorry. Obviously, you know where I land. Just to get back to this China thing, only one of us has faced the Chinese in open combat. This is in Shanghai. I'm the guy on the right. Now, admittedly, we're patted and shook hands afterwards, but I feel like the concept is there. I've faced them with weapons. Thank you.
Okay, so Stefan and I went over, so let's take a break. Let's come back in 10 minutes. We'll convene the panel, and we'll get you all involved pretty quick.